Hi, I'm Dorcy Pruter, the CEO and founder of the Conscious Co-Parenting Institute, and today I'm here with the fabulous Dr. Craig Childress, and delighted that you're here with us today. Thanks so much for coming out to the studio to record.
Yeah, thank you for the invitation.
Thank you. And we have some questions that have come up quite a bit as you have so generously been writing blog posts and putting out information for target parents and alienated children. And if you haven't come across Dr. Childress's work yet, please be sure to check out his blog. It's drcraigchildressblog.com, correct? And then also we have a YouTube channel with a bunch of YouTube videos about the pathogenic parenting or attachment-based parental alienation. And there are several videos up there, and we'll be adding videos as we go along and as new things come out that Dr. Childress has been working on. And so today I just want to spend a little bit of time talking to you about the work that you're doing and a lot of the questions that we get asked at the Conscious Co-Parenting Institute. And we get target parents calling a lot, or attorneys and even therapists and social workers, people working with these families that are struggling. And so one of the questions I want to start with is the fact that mental health really has missed this pathogen, missed this problem. And I'd like for you to answer really what you believe an effective role of the mental health community or mental health therapist in working with these families.
Well, the idea of parental alienation developed in the 1980s with Richard Gardner when he first identified the type of pathology, or that there was a new pathology that people weren't identifying at the time. And he coined the phrase parental alienation and suggested that it represented a new syndrome within psychology. And psychology doesn't like new syndromes. They're very conservative. And so they really wanted the pathology to be defined within standard and established constructs, rather than, they don't like a flurry of new different types of syndromes, battered woman syndrome or parental alienation syndrome. And so they were very reluctant to adopt Gardner's model. In addition, all of his symptom indicators were anecdotal, and they had no basis in established types of symptoms. And then he made some ill-conceived statements about sexual abuse that inflamed the situation even more and polarized the mental health field. And I think Gardner is to be commended for identifying this trauma pathogen, something that people hadn't recognized as a pathology before. But then when he proposed a new syndrome, I think he took the debate into a problematic area, because in actuality, we don't need a new syndrome.
Right.
Pathology is pathology. And this is parental alienation, or the symptoms of what's been called parental alienation, are established psychological pathology that we've known about for a long time in family systems theory and attachment theory, personality disorders. And so I think if we return to the foundations of established mental health constructs and principles, it will serve us a lot better in dealing with the pathology. Now, I've kept the term parental alienation because so many people are familiar with it.
Right, that makes sense.
But I think we should return back to the foundations of things. Now, in terms of the role of mental health professionals, it is our job to identify, diagnose, and treat pathology.
Makes sense.
Yeah, all types of pathology.
Right.
And in addition, we specialize. So prior to coming into parental alienation, my specialty was in ADHD, autism spectrum. I don't treat Iraqi war vets. I don't treat that type of pathology.
Right.
I'm competent enough to know what the PTSD trauma looks like, so that I can refer to somebody who does treat that specialty. Or anorexia. I don't treat anorexia, but I know what it looks like so that I can refer to somebody. And mental health needs to look at this particular type of pathology. It's very complex. It's a trauma pathology that's being passed on from one generation to the next. It's got personality disorder dynamics with it, attachment system features with it. It really represents a special type of population, a special population that requires specialized professional knowledge and expertise to appropriately diagnose and assess and treat. And so mental health, that's their obligation at this point, is to properly and accurately assess, diagnose, and treat this particular type of pathology and to become familiar with it.
So just to summarize that, what I heard you say, I heard you make a couple of really good points. One, that you're not negating the work or trying to make the work that Dr. Gardner did a falsehood per se. You agree with some of the things in the work that he did, but he took it to a place that it didn't need to go. There was no need to create a new syndrome. And that within mental health has an obligation to the patients that they serve to serve within the confines of their what's the word you said? It's losing, I left my brain, but
their practice.
Their practice, right. Their competency, right. So you're saying that mental health professionals that are working with this special population should have special skills to recognize it, diagnose it, and possibly treat it or do something or refer it to somebody who can.
Right.
Okay.
And that's true whether we're talking about mental health or we're talking about the medical field.
Sure.
If you have a plastic surgeon, can be a great plastic surgeon, shouldn't be doing open heart surgery.
Exactly.
And if you have an attorney who's great in family law, shouldn't be doing international law.
Right.
And so
makes sense to me.
You need to know what you're doing and work within the boundaries of your competence.
Makes perfect sense to me. And I'm sure it makes perfect sense to our audience and mainly probably target parents who are struggling with people who don't understand the pathology of what their family is struggling through, which seems to be a common thing.
And that's, I have to critique mental health a little bit in that the major failing is that mental health is looking at this like an oppositional defiant disorder. That's their failure, is their misunderstanding what the pathology is, because they don't have, the therapists who are working with us, many therapists, don't have the background training in trauma and the attachment system and personality disorders. They're child therapists. Child therapists don't have training in personality disorders or experience with it. Unless you're working early childhood, you don't get training in attachment system.
Right.
And so they're looking at it as though it's a standard type of oppositional defiant, and it's not. It's far from it.
Makes sense. I also like the fact that you said getting back to the foundations of mental health, which is the name of one of your most recent books, which is fabulous. If you haven't read it, make sure that you go to the link below this video and pick up a copy of Foundations, because Dr. Childress very generously has explained this pathology, and not just in the terms for mental health, but also for us as parents to really understand what's happening with regards to this dynamic. And I love that you said getting back to the foundations. I'm assuming that that's why you named the book Foundations, but it makes sense to me.
Very much like that we need to establish what the pathology is and define the pathology within standard and established psychological principles. And so that lays the foundation for which we can then diagnose and treat and understand what the pathology is.
Almost a double entendre. And we've worked on some cases together, and I'm really grateful for that, because I've been doing reunification through the High Road Protocol for 7 years, and one of the pieces that was really missing for getting families into a reunification protocol that works was a diagnosis, right? And since the syndrome, as we all know, is as everybody likes to say, junk science, and they have to toss it out. So how do we diagnose these families? We were really struggling with that. And we worked on one case in particular, and very quickly, a case that had gone on for 4 years and 30 days. You and I were able to help this parent with just a small piece of evidence that identified the child's pathology, and we were able to get the court to order a protective separation, and the child was able to be recovered in 4 days in the High Road. And I'm so grateful, because that piece was missing for me, and so I thank you for all this amazing work you do, because honestly, it really does make it available to so many more people. And so another case we worked on, and I wanted to mention that, but another case we worked on, there was a struggle with the proper protective separation, and out of helping that family with diagnosing and the work that you were doing, there was a new old concept that was birthed, which I think is really beautiful. And I'm going to show you this here. If you haven't picked this up, make sure you pick this up. And it's called the single case ABAB design. And you can also pick a copy of this up on a link below if you want to pick this up. Dr. Childress created this based on a case we were working on. So can you just share a little bit with the parents and the people watching what this really does for them and what it really is?
At its core, the pathology that we typically describe as parental alienation is not a child custody issue. It's a child protection issue.
Right.
The pathology of the allied and supposedly favored parent is inducing pathology in the child, significant pathology. And we need to, before we can treat the pathology of the child, we need to separate the child from the pathogenic parenting, from the parenting that's producing the pathology. Otherwise, we're going to just turn the child into a battleground.
Right.
And so the first obligation we have is to protect the child. Then we can treat the child and restore the child. In order to get the protective separation of the child from the pathology and from the pathogenic parenting that's producing the child's pathology, we need the court, because the court is the only system that has the power to protect the child. And right now, within the court system, courts are reluctant to provide the protective separation until they get a clear message from mental health.
Right.
And so our first obligation is to get a clear message from mental health. But in the meantime, I know that many targeted parents are struggling with the court system, trying to get the court system to do what's right by their kids and protect their kids and take the steps necessary to protect their kids. So we were working on a case where prior to my involvement, you had gotten the protective separation, you had fixed the kids, but then it wasn't maintained long enough and it went back to the parent. And we were trying to get a second protective separation so you could come back in and refix the kids.
Right.
And as I was thinking about it, I went, well, wait a minute, that's actually a single case model within psychology,
right,
where we put the child through a series of phases. So we start with a baseline phase, and we do an intervention, then we go back to the baseline phase, and then we do the intervention again. And we can see the rise and fall of symptoms, whether it's autism or school-based interventions or anything where we use that A-B-A-B. It's called a reversal design.
Makes
A
sense.
is the first baseline, B is a treatment, A is a baseline, B is a treatment. And I said, we can actually apply that to this sort of situation. Rather than go through a costly, 6 months of child custody evaluations,
right,
we can actually put in a single case ABAB reversal design and get an answer within 12 weeks about what the pathology is. In experimental research, there are two types of designs that can prove causality. One is what you classically think of as a big experiment where you have a lot of subjects and you do all. The other, though, is this single case design. It was the favorite design of B.F. Skinner, who is the father of behaviorism. He says, if you can't see the results, then what's the point? And so
makes sense.
Yeah, and so it's very useful. It's very powerful in demonstrating the effectiveness of treatment and causality. So what we did is apply the single case model to both an assessment and a remedy. So if the court is wondering, is this parental alienation? Is this negative parental influence on the child that's producing the child's rejection of the parent and rejection of court orders and stuff? They can actually order this as an assessment of that.
Brilliant.
The baseline phase is that the child's rejecting the parent and doesn't want to have anything to do with the parent, so you get some ratings during that, and we rate the child's symptoms throughout the whole time. The intervention phase is we then separate the child from the allied, the allied and supposedly favored parent during that treatment phase. Now, this would not be possible, however, if it was just me relying on therapy.
Right.
Because therapy would take about 6 to 9 months to restore the child. That's too long.
Right.
But when you introduced me to the high road protocol and I looked at it and I said, oh my gosh, this can resolve things within a matter of days.
Right.
Which then allows this to actually work, because if the high road protocol comes in, restores the child's normal range functioning within a matter of days, then we put this sort of behavioral program into place where the child has to earn successful days towards successful weeks,
right,
and based on parental ratings of how successfully the child's doing. And that's actually a strategic family systems intervention. Because right now, the child's rejection of the targeted parent is giving power to the allied parent.
Right.
And this reverses it, so that now when the child is nice to the targeted parent, that actually is in support of reducing the protective separation. So it takes the child out of the middle. The child is actually given permission to be nice to the targeted parent as a way of ending the protective separation and being loyal to the allied parent. And so it gives the child a reason to stop the negative behavior.
Right.
And as soon as a child earns 6 weeks of appropriate behavior, there's actually bonus weeks in there, so the child can actually get it down to 4 weeks if they're really good. And so just a month of normal range kind of good behavior, then we end the protective separation. Child's fixed. The child's symptoms are gone. So now everything's fine. We reintroduce the allied parent.
Right.
And there's two possibilities. One is the child's symptom stays gone. In which case,
Yay.
Great. Yeah. 6 weeks, we've solved the whole problem. We don't need years of court battles and all of this stuff.
Right.
The other possibility is that when we reintroduce the allied parent, the symptoms come back.
Right.
Well, then we have a clear indication where the symptoms are coming from.
Exactly.
When we separate the child, the symptoms go away. When we initiate the child, the symptoms come back. If the symptoms come back, we introduce the fourth phase, which is we reintroduce the protective separation, High Roads protocol again, restore the child's functioning. But this time, before we reintroduce the other parent, we're going to have to take some steps to make sure the child's stable.
Right.
Okay? And so we keep stepping up the level of intervention based on the need for the situation. And this gives the court an opportunity to get evidence-based, empirically validated information on which to base their decisions, rather than the judgment of a child custody evaluation or testimony and go this way. Let's find out what's going on.
First-hand experience, not what somebody else is saying or thinking from an evaluation perspective per se, but what actually is happening with the child based on how the child is behaving. And so I just want to make sure everybody understands this is the assessment version of the ABAB, and this is where the maybe the therapist hasn't made a diagnosis, so they don't feel comfortable with the fact that I don't know what it is, or sometimes we've heard this, we don't really want to label somebody. And even though, would you not agree that is your job as a therapist or a psychologist to identify, to label the pathology? But, this is a fairly new language around it, I guess, if you will. But the ABAB has been around forever, right? I mean, not forever, but for a long time. And it's an accepted model. And so you were saying, this is really what he was explaining was the assessment. If you have a therapist and they're like, well, I don't know, maybe you can say, well, request the assessment, request the ABAB, a protective separation. It's temporary. We're not saying, sorry, that parent's out, no more. We're saying, look, we're here to protect the child. And this is a child protection issue, not a child custody issue. We must protect the child. We bring the child into protection and then do the intervention.
And the intervention period, the B period, the first intervention period, is entirely within the child's control.
Right.
All we're asking from the child is normal.
Right.
Okay? We're not asking exceptional.
Right.
We're just asking a rating of 4 or higher, which is just sort of normal, sometimes grumpy, sometimes okay. Just a normal kind of kid.
Right.
And that is not an unreasonable expectation for the child.
I don't think so.
Get a normal out of child, stabilize the child for a little while, the child's normal, everything's good, and then we say, yeah, okay, let's move on.
Right.
And so the idea of putting it within the child's control is critical. That we're not imposing something. If the child doesn't want to be normal, if the child wants to continue being symptomatic, well, it's going to take longer.
Right.
But that encourages the child then to restore their normal range behavior so that we can end this and move on as quickly as possible. And again, I think this is predicated on the fact that the High Roads protocol can quickly reestablish a kid within a matter of days.
Right.
So now we've got normal to start with.
Right.
And now we just need to kind of keep it going for a little while. And yeah, it's not unreasonable to expect the child to just be kind of normal average range.
Right. Brilliant. I'd like to move on to your next book, which is coming out. It's a wonderful another piece of this process. And one of the things I love about collaborating with you and connecting with you is that you, as well as me and many others, are on a mission to end this this pathology, right? This family dynamic, and to end parental alienation. We are going to save all the children. We're not leaving kids behind. And so we're holding people, you, me, anybody, right? You've done all this amazing work to hold the professional community to a standard that they should be holding themselves to anyways, I would think. And so because this pathogen is so vile and it's really infected the mental health community, I don't think we want to get a message out there that we want to alienate the mental health community. We want to recover our allies in the mental health community. And I've heard you say that, and I love that, because I think that's really true. And so you have another book coming out, and it's called Professional Consultation, and it's an attachment-based model of parental alienation that Dr. Childress has so generously written. Yet again, another piece. You write faster than anybody I've ever seen. And I always get something from you saying I'm going to be releasing something, and then 2 days later I get it, and I'm like, wow, okay. This is a great piece of literature and information, and it's a wonderful handbook. It's not super big. I think it's 50 pages? 50 pages, 55 pages, and explain to the mental health community and really the families, the parents that are struggling with this, what is this for? How is this going to help?
I wrote this book for targeted parents to give to the mental health professional.
Okay.
And that's why it's called Professional Consultation.
Makes sense.
It is my consultation to the mental health professional. And essentially, I'm writing it as a psychological consultant to the targeted parent.
Great.
And so they are using me to explain in professional language to the mental health professional what the pathology is regarding this. And it's asking the mental health professional to specifically address for this type of pathology, and to document in the notes the results of the assessment. Either
right.
It was the symptoms are there or they're not there. And if not there, why not? Which symptoms are absent? And what this is designed to do is begin to help the targeted, or empower the targeted parents to expect professional expertise and knowledge from the mental health profession. That within the medical profession, going back to the plastic surgeon analogy, if a plastic surgeon suddenly decides to do heart surgery, and because of that the patient dies because a plastic surgeon isn't competent to do heart surgery, that's malpractice.
Sure, makes sense.
And the question is, why isn't that also malpractice in the mental health field? Well, in fact, it is. That mental health professionals are obligated by our professional practice standards to be competent in what we treat. And the problem with a lot of mental health professionals out there right now is that they don't understand the pathology that they're treating. They don't understand the attachment system, personality disorders, role reversal relationships, and they're looking at this as if it's oppositional defiant. And they're misdiagnosing the child's symptoms and the pathology within the family. And so what this booklet does, it's based on Foundations. Foundations provides the theoretical structure at a very detailed level of analysis. Then based on that, I can summarize that for the mental health professionals, because if the target parent gives Foundations to the mental health professional, they may not read it.
Right.
50 pages, you got to read it. And I cite the literature in this booklet. I cite the ethics codes that are involved in this booklet. And I was simply asking mental health professionals to assess for this specific pathology, personality disorder, attachment, delusional belief systems, and to document the results of that assessment.
So if a mental health professional, if a parent takes this in and gives this to the mental health professional working with their family, and they say, great, thank you so much, and then they don't do anything, because we've seen that a lot, obviously not with this, because this isn't out yet, but let's say this is out, and the parent takes this to their therapist and says, I've been working with Dr. Childress via watching his videos. I've read his book Foundations. I've studied the ABAB. This is what's happening to my family. Here's a professional consultation book that Dr. Childress has written for you. And they give it to the mental health professional. The mental health professional says, awesome, that's great, blah, blah, blah. And that's where it goes. And nothing happens. What would you suggest to that parent, and how much time do you think should elapse before something should be done about that if their therapist isn't doing anything.
The ethical practice standards for mental health, the American Psychological Ethical Principles, requires that mental health professionals consult with other professionals as appropriate to take care of their patients' needs. That is a specific standard that I cite in the booklet to start with. And so the mental health professional that does not read the booklet is in violation of that particular standard immediately.
Okay, can you look at the camera and say that? Because I'd like to have that said out loud with this. And if you... I just think that's so important, because I think oftentimes target parents get so destabilized by this pathogen that they feel paralyzed, and they're relying on mental health as their ally to help protect their children, because that's their job. And they're maybe working with somebody who is unfamiliar, and then they bring them something and then nothing happens, and then they feel like they can do nothing else. And I hear this all the time. And so I would really love for you to say that one more time, because I think it's so powerful, and I really think that they need to hear it again.
So let me just read the standard. It's standard 3.09 of the Ethical Principles of Psychologists and Code of Conduct of the American Psychological Association. This is our standards of practice. Typically, at least in California, they are codified into law. That this is the law that we must follow as professionals, mental health professionals. 3.09 says, and I start the booklet with it. This is so I alert the mental health professional, this is the standard which I'm offering this consultation to you. And the standard reads, when indicated and professionally appropriate, psychologists cooperate with other professionals in order to serve their clients' patients effectively and appropriately. And so what you're asking from the mental health professional is that they cooperate with me to serve their patients, you, effectively and appropriately. If there's three possible options that you can have when you give the mental health professional this booklet. The first is that they will read it and become competent. They'll go to foundations. They will learn more about the pathology, and in order to accurately assess and diagnose, hopefully. The second possibility is that they'll say, ooh, wow, this is something I don't know about, and you know what? This is beyond my boundaries of competence, and I'm going to decline the case. Excellent. That's what they're supposed to do. If an anorexia patient comes into me, I say, well, nope, I'm sorry, this is beyond my boundaries of competence, and I refer to somebody who does treat for anorexia. That's what they're supposed to do. The third possibility is that the therapist chooses to remain ignorant and continue to treat. They're not allowed to do that. The Ethics Code of the American Psychological Association specifically tells them not to do that. And under 2.01a of boundaries of competence, you must be competent in what you're treating. And if they intentionally refuse to acquire information, can you have the booklet back for a second?
Sure.
There's a second. I end the introduction with another ethics code standard, which is 2.03 regarding maintaining competence. And this says, psychologists undertake ongoing efforts to develop and maintain their competence. That's 2.03. If they are refusing to take efforts to maintain their competence, even as you request them to do, they're refusing to consult with another mental health professional and increase their knowledge as you are requesting them to do. And in turn, because of they practice beyond boundaries of competence, they wind up harming you and the client. That's a violation of 2.01a, and that's a violation of 3.04. Mental health professionals are not allowed to be ignorant and incompetent. They're not allowed to do that. That's illegal. That's beyond. That's in the practice standards, which are codified into the law. And the issue is with the prior Gardnerian model, when we had this new syndrome, people could say, the therapist could say, well, parental alienation doesn't exist, and there was no way to hold them accountable. And so when I first took a look at the pathology and the problems that we were faced with, I said, we need to solve that. We need to bring this definition of what parental alienation is, what the pathology is, within standard and established psychological principles so that we can then hold mental health professionals accountable.
I love that.
And that's what foundations did, And now this booklet is the next step on that.
I think that's fantastic. We're going to take a quick break and get back to you after our quick break. But we have a lot more to share with Dr. Childress today. So thanks so much for watching. We'll be right back with you.